morning to all. I am very grateful to be part of the Sta Ana Hospital. And I'm very thankful to our honorable and respected Medical Director, Dr. Grace Padilla, and to Dr. Ciscon, Dr. Resha, Dr. Ravalo, and all of the organizing committee, without whom this webinar series would have not been possible. Thank you, doctors and colleagues. We are now celebrating the National Women's Month, and this serves as a venue to highlight women's achievements, women empowerment, and gender equality. And today, we will be discussing about family planning that helps protect women from any health risks brought about pregnancy and delivery. To promote quality reproductive health, continuous provision of family planning is one of the vital and essential health services needed, especially during the health crisis brought about by the COVID-19 pandemic. Family planning amidst pandemic. I am Dr. Jovelyn Catherine Ardenalina, and I will be discussing about family planning. It is still alarming to know that the world's population is steadily increasing, based on the Worldometer this March 2022, to more than 7 billion. And as of 2020, the Philippine population is at 109 million, according to the Philippine Statistics Authority. Out of 18 regions of the Philippines, NCR, or the National Capital Region, is at the top 2 of the most populated region in the country, based on PSA. And having said that, this growing population has been a constant problem that burdens the economy. And among the different cities of the National Capital Region, Manila was on the top 2 with the highest number of the total population. The Commission on the Population and Development, or POPCOM, projected an increased birth rate when the COVID-19 pandemic started because more families stayed at home and access to the family planning method is limited. During community quarantine, family planning provision declines. The health crisis creates another crisis with an approximate of 102,000 unintended pregnancies among adolescents by the end of 2020. Unintended pregnancies, especially among those adolescents, have different pregnancy complications, such as abortion, toxemia in pregnancy, malnutrition, prematurity, and stillbirth. Family is the basic unit of the society and the keystones of the national building. Therefore, as a healthcare provider, we should encourage people to see the importance of family planning. It is a life-saving intervention, and we need to promote the service in order to avoid increasing morbidity and mortality resulting from unplanned pregnancy. Due to this pandemic, the Department of Health and Commission on Population and Development, or POPCOM, strengthens the promotion of responsible parenthood and family planning programs through education and counseling. During enhanced community quarantine, teleconsultation has been the platform of the family planning service provision. And in other areas of the country, such as in Bicol, they launched the Family Planning Ayuda Express, the Family Planning on Wheels, for the continuous delivery of the family planning methods. As a healthcare provider, we should know what is the Philippine Family Planning Program. The family planning vision is to empower women and children to live healthy, productive, fulfilling lives with the right to achieve their desired family size through quality, medically sound, and legally permissible family planning methods. This is with the guiding principle of the following: respect for sanctity of life, respect for human rights, the freedom of choice and voluntary decision, and respect for the rights of the clients to determine their desired family size. The mission of the family planning is to ensure the availability of family planning information services to all men and women of reproductive age who needs them. And the goal is to provide universal access to the family planning information and services whenever and wherever they are needed. My learning objective today is to enumerate the different types of family planning methods, discuss the mode of action and effectiveness of each family planning method, and enumerate the family planning methods during the time of pandemic that can be used. What are the different kinds of family planning methods? So we have the natural family planning method. which includes the following: basal body temperature, Billings ovulation or cervical mucus method, symptothermal method, standard days method, and lactation amenorrhea method. For the temporary method, we have injectables, condom, pills, implants, or IUD. If we talk about the long-term family planning method, we have intrauterine device and permanent methods such as non-scalpel vasectomy and bilateral tubal ligation. As a healthcare provider, we should advise our clients that the only family planning method that is 100% effective is the abstinence that must be practiced until they reach the proper age to start a family. The natural family planning method, or also known as fertility awareness-based method, has different types. This FAB method determines the fertile and infertile periods of a woman, with observation of signs and symptoms of fertility and infertility during the menstrual cycle. And during that time, we could time the sexual intercourse to achieve or avoid pregnancy. The effectiveness of this FAB method depends on the couple's ability to identify fertile and infertile periods and motivation to practice abstinence when required. Here are the different types of FAB methods. We have to stress out that the fertility awareness-based method is only be used by regularly menstruating women with at least 3 regular cycles and have normal secretion and is not postpartum or breastfeeding clients. So we discussed the different types of family planning method under fertility awareness-based method. The first of which is the cervical mucus billing ovulation method. This chart is the basis of the daily observation of what a woman sees and feels at her vaginal area throughout the day. Changes in cervical mucus indicates whether days are fertile or infertile and can be used to avoid or achieve pregnancy. The woman is instructed to observe and record the feeling of dryness or wetness in her vaginal area during the day. She must abstain from sexual intercourse during the fertile or wet days. So, on the dry days following menstruation, couples can have sexual intercourse on alternate nights. On the 4th day after the last day of wetness, all dry days are absolutely infertile. So this cervical mucus method is 97% effective with perfect use. However, with typical use, it is only 77% effective. Next method is the basal body temperature. This is based on the changes in women's resting body temperature, which is lower before ovulation until it rises to a higher level after ovulation. All days from the start of the menstrual cycle up to the 3rd high temperature reading are considered fertile days. Infertile days begin from the 4th day of the high temperature reading to the last day of the cycle. The effectiveness of this basal body temperature is 99% when perfect use and 80% when typical use. Next is the standard days method. This works only for women with menstrual cycle of 26 to 32 days. And this method identifies the 8 to 19 as the woman's fertile period. Colored beads are used to help women keep track on her fertile and infertile days. This standard days method is 95% effective with correct use and 88% with typical use. A woman is instructed to start counting on the 1st day of her menstrual period in this red bead. This is the iCycle bead, wherein it is a smartphone app that allows a woman to use standard days method electronically. The application asks for the 1st day of the period and from that day creates a calendar using the cycle bead. This tool determines the woman's fertile and infertile period and alerts a woman through an alarm system when and when not to have sexual intercourse. Here is a tabulation of the effectiveness of FAB method. With a perfect use, they are very effective. Next is the lactation amenorrhea method. How does it work? This is the usual question regarding lactation amenorrhea method. To answer this question, we explain that a woman who breastfeeds secretes a hormone called prolactin. And this prolactin stops the ovulation. Lactation amenorrhea method is very effective with only 1 to 2% failure rate. A postpartum woman can use this lactation amenorrhea method as long as she is fully or nearly fully breastfeeding, amenorrheic, and her infant is less than 6 months old. With perfect use, this lamb is 99% effective. What do you mean by perfect use? Perfect use means when a woman breastfed her infant on demand with no more than 4 hours interval during day and 6 hours at night. As a typical use, it is still effective with a 98% effectivity. Fully breastfeeding means that the infant receives no other liquid or food, not even water, in addition to breast milk. However, the nearly fully breastfeeding means that the infant receives some liquid or food in addition to breast milk, but majority of the feedings, or 3/4 of all feeds, are the breast milk. Lamb can be used by mothers living with HIV as long as they are taking antiretroviral therapy. When a woman takes ART, there is significant reduction in the risk of HIV transmission through breastfeeding. There are conditions that affecting newborn that may make breastfeeding difficult, such as with congenital deformities of the mouth, jaw, or palate, newborns who are small for days or premature, and needing intensive care units, and certain metabolic disorders. There are also medications that are not recommended for breastfeeding women, such as antimetabolites, bromocriptine, anticoagulants, corticosteroids in high doses, cyclosporine, ergotamine, lithium, mood-altering drugs, radioactive drugs, and reserpine. Next, we talk about condoms. This male condom acts as a barrier that prevents sperm from getting into vagina, that helps prevent both pregnancy and sexually transmitted infections. Condoms, in order to be effective, it must be used correctly and consistently every time one is engaging sex, and with perfect use, it is 98% effective, and with typical use, it is only 87% effective. Based on medical eligibility checklist, we do not offer condom when either or both of the sex partners have severe allergy to latex rubber. This is the female condom. The female condom forms as a barrier that keeps sperm out of the vagina and helps prevent pregnancy and STIs as well. The effectiveness of this condom, when perfectly used, it is 95% effective, while typical use is 79% effective. Every individual have different family planning needs, and we have a basis in provision of the family planning method. We have the medical eligibility criteria for contraceptive use that is being provided by the World Health Organization last 2015. At present, we are using the medical eligibility criteria wheel for contraceptive use of 2015. So what is the WHO medical eligibility criteria for contraceptive use? This is a tool for assessing clients on their eligibility for initiating and continuing the use of specific contraceptive methods based on the specific criteria developed from evidence-based standards. We have the categories 1, 2, 3, and 4. In general, with the category 1 and 2, we can provide a method. However, in 3 and 4, we cannot give the method to our clients. With this WHO medical eligibility criteria wheel for contraceptive use, we have 9 common types of contraceptives, such as combined oral contraceptive, combined contraceptive patch, combined vaginal ring, combined injectable contraceptive, progestin only injectable, progestin only implant, levonorgestrel releasing IUD, and copper-bearing IUD. We have here the medical eligibility criteria table, wherein we have the personal characteristic and reproductive history of our client, and different kinds of contraceptive methods, and the criteria of eligibility of each condition. As a healthcare provider, before provision of any family planning method, we should be certain that our client is not pregnant. And to rule out pregnancy, we are using the pregnancy checklist. If the client answers no to all of the questions, pregnancy cannot be ruled out using the checklist. Hence, rule out pregnancy by other means such as pelvic examination, pregnancy test, or transvaginal ultrasound. However, if the client answered yes at least one of the questions, you can be reasonably sure that she is not pregnant. Hence, we can provide a family planning method for this client. After client assessment, we could now provide temporary methods. First, we have here progestin-only contraceptive methods. This hormonal contraceptive method contains progestin, which inhibits ovulation and thickened cervical mucus. It is safe for breastfeeding mothers with no decrease in milk production. However, the most common side effect of this method is irregular bleeding. Pills of the POP are all active hormones, and they should be taken regularly at the same time because late intake make it less effective. It has no steroid-free interval, and the return of fertility is immediate. For breastfeeding women, POP are very effective with 99% on the typical use and 99.5% with the perfect use. However, it is only 93% effective for women who are not breastfeeding. Being a family planning provider, we should be meticulous with the history of our client because there are certain drugs that decreases the effectiveness of POP, such as anticonvulsants, rifampicin, lamotrigine, and other drugs listed in the slide. Timing of POP intake depends on the situation of a client. For example, a first-time user with no previous family planning method can start taking POP in her first 5 days of menstrual cycle. However, if her cycle is more than 5 days, she can still use the POP, but with backup methods such as condom in the first 2 days of intake of POP. For the previous COC users, she can take the POP immediately as long as she takes her previous method correctly and consistently. For the previous DMPA users, she can start taking POP the same time when the next injection of DMPA is due. For a previous intrauterine device or IUS users, she can start taking POP the same day of the removal of IUD or the IUS. After miscarriage, client can start taking POP in her first 7 days of miscarriage. However, if her miscarriage is more than 7 days, she can still use the POP but with backup methods such as the condom in the first 7 days of intake of POP. For clients who are postpartum, whether breastfeeding or not breastfeeding, they can start immediately. The next family planning method that contains progestin is the progestin-only injection. The progestin-only injectables have 3 available preparations in the form of depo-medroxyprogesterone acetate, depo-sub-Q, and Noristat. The depo-medroxyprogesterone acetate or the DMPA-SE is the newest subcutaneous DMPA formulation available in Uniject, a single-use syringe. This form provides slower and more sustainable absorption and is given every 3 months. It is injected into the anterior thigh or abdomen and may be self-administered at home. This has been approved by the US FDA since 2004. The progestin-only injectable has 99% effectivity when perfectly used and 96% effectivity when commonly used. This effectiveness is dependent on having injection on time. Take note that the injection site should not be massaged or pressurized to avoid accelerated absorption of the drug. For the POI, the return of fertility is delayed. An average of 9 to 10 months for the MPA and an average of 6 months after the last dose of NET-N injection. The use of the MPA is associated with slight decrease in bone mineral density, but is reversible. However, the bone density loss is greater during pregnancy than taking the DMPA. There was an issued statement by the WHO that there should be no restriction of the use of DMPA among aged 18 to 45 years, who are otherwise eligible to use the method. DEXA studies or monitoring of the bone mineral density is not recommended, and supplementation of the vitamin D and calcium will benefit a woman's general health. The timing of POI intake depends on the situation of a client. For the first-time users with no previous family planning method, she can start taking POP in her first 5 days of menstrual cycle. However, if her cycle is more than 7 days, she can still use the POI, but with backup methods using condom in the first 7 days of administration of POI. For the previous COC users, she can take the POI immediately as long as she takes her previous method correctly and consistently. For previous IUD users, she can start taking POI the same day of the removal of the IUD. And after miscarriage, a client can start taking POI in her first 7 days of miscarriage. However, if more than 7 days, she can still use the method but with backup methods such as condom in the first 7 days of intake of POI. In cases of clients who are postpartum breastfeeding, she can have POI 6 weeks postpartum, and when not breastfeeding, they can start immediately. POI can be administered 2 weeks early for the net end and DMPA, or 2 weeks late for the net end and 4 weeks late for the DMPA. If the client has a BP of more than or equal to 160/100, we should not give this method. Next type of family planning method is the progestin subdermal implant or PSI. Progestin subdermal implant has a single rod implant containing 68 milligrams of etonorgestrel, and this is the only implant that is FDA approved that is effective for 3 years. Only trained individuals can provide this method. This table shows different types of progestin subdermal implants, and the implant on NXT is the one being provided by the DOH. The effectiveness of PSI depends on having the implant inserted and replaced on time. It is very effective to 99.95%. Studies have shown that the implanon have not found that the effectiveness decreases for heavier women. For the PSI insertion, ideal timing depends on the client's situation. For new acceptors, the timing of insertion is during the day 1 to 7 of her cycle. The client can use backup method for the first 7 days after the insertion. When the client uses combined hormonal contraceptive method, she can take the PSI immediately. For the POP user, she can have PSI inserted any day during the treatment and just stop the pill. For the DMPA user, the PSI insertion should be scheduled when the next injection is due. When IUD users, she can have PSI inserted the same day as the removal of IUD. And in cases with miscarriage, we can provide the method any day. When a client is a postpartum, whether she is breastfeeding or not, she can have the PSI immediately or anytime after delivery. Next family planning method is the combined hormonal contraceptive. This method contains hormones similar to the women's natural hormones such as estrogen and progesterone that prevents ovulation and thickens the cervical mucus. However, it is not recommended for breastfeeding women because it decreases the milk production. Listed here are the different kinds of combined hormonal contraceptives. First type is the combined oral contraceptive, or known as pill or oral contraceptive. We have 2 types of formulation of COC. First is the monophasic or the fixed dose combination, which contains 21 active pills and 7 inert or pill-free days, in which withdrawal bleeding occurs. And the second one is the combination of phasic, the multiphasic, biphasic, and triphasic. It has 2 to 3 different doses of estrogen and progestin. Tablets of the same dose given for 5 to 11 days in the 21 medication period. It has not been found to have an advantage over a fixed dose. The rationale given for the use of this type of formulation is that a lower total dose of steroids is administered without increasing the incidence of unscheduled uterine bleeding. This table shows the different kinds of COCs in the Philippines, and we have four generations of COCs. The first generation have the highest concentration of ethinyl estradiol, while the fourth generation have the low dose of ethinyl estradiol. The effectiveness of the COC when perfectly used is 99.7% effective, and when typically used, it is 92% effective. The effectiveness can be attributed to the correct and consistent use of the method, and with the proper storage, observance of shelf life, and expiration date. The effectiveness of COC decreases among clients who experiences vomiting or diarrhea, and also when there is a drug interaction. Here are the different kinds of drugs that decreases the effectiveness of the COC. So the timing of provision of COC, for the new acceptor, we can provide COC in her days 1 to 5 of cycle. However, if more than 5 days later, she can use backup method for the first 7 days of intake. For the POP users, she can shift to COC any day during treatment. And for the DMPA users, she can start the COC when the next injection is due. For the IUD or IUS users, they can start COC intake the same day as the removal of IUD or IUS. And in cases of miscarriage, we can provide COC on the first 7 days after miscarriage. However, if more than 7 days later, the client must use backup method for the first 7 days of intake. For the postpartum breastfeeding women, we should advise that COC should be started at 6 months postpartum. However, if the client is not breastfeeding, we can start giving COC 3 weeks postpartum. In cases that the client needs to intake her pill, we should remind them to always take a pill as soon as they remember and continue taking pills one each day. Also, if they miss pills 3 days or more in a row, or if they start the pack 3 days later, we should advise our clients to use condom or avoid sex for the next 7 days. If the client misses 3 or more pills in a row in week 3, we advise them to use condom or avoid sex for the next 7 days. Also, we advise them to skip the non-hormonal pills and start taking pills at once from the next pack. If a client misses any non-hormonal pill, so this is the non-hormonal pill, in a 28 packs only, we should discard the missed pills and continue taking one each day. Next, we have here the combined injectable contraceptive or CIC. The only CIC currently available in the country is the Norepam, which contains noritesterone 50 mg and estradiol valerate 5 mg. This method is being injected every 30 days, with 7 days late or advance of administration. There is 1 month longer delay in return of fertility after the woman takes this kind of method. The effectiveness of CIC in preventing pregnancy in the first year of use, when correctly used, it is 99% effective, and typical use, it is 97% effective. The timing of administration of CIC is same as with the COC. Although not available in the Philippines, it is also nice to know that we have contraceptive patch and contraceptive ring. The contraceptive patch, also called Ortho-Evra and Edra, is a thin square of flexible plastic worn on the body. These hormones slowly absorb through the skin into the bloodstream. The changing of the patch is every 3 weeks in a row, and on the 4th week, there will be a monthly bleeding and no patch needed. So this is the vaginal ring or the Nova ring. It is a flexible ring that a woman wears in her vagina. It contains hormones that is being absorbed through the vaginal wall directly into the bloodstream. It is inserted like a pessary. Then the ring will be taken out at the end of the 3rd week and disposed. When perfectly used, it is 99% effective, and with typical use, it is 93% effective. We talk about now the intrauterine method. There are 2 types of intrauterine methods. First is the one being provided by the DOH, and the second one is the intrauterine system, which contains levonorgestrel. This method inhibits sperm transport into the upper vaginal tract and inhibition of ovum transport. This is caused by the active substances released from the IUD and IUS together with the product derived from inflammatory action present in the luminal fluid of the genital tract. These substances and fluids are toxic to the spermatozoa and oocytes, thus preventing encounter of healthy gametes and formation of viable embryos. So this table shows the comparison of the levonorgestrel intrauterine system and the copper iodine. For the effectivity, the levonorgestrel is 3 to 5 years and the copper iodine is 12 years. The LNG-IUS contains levonorgestrel, while the copper iodine contains 68.7 milligrams of copper and 176 milligrams of barium. Since the levonorgestrel IUS is a hormonal method, the client experiences a lighter bleeding or no bleeding at all. There is a reduction in menstrual cramps and experiences other hormonal side effects. While in the copper iodine, there is a regular or heavier or longer bleeding, and there is also increased menstrual cramps. For the non-contraceptive benefits, since the LNG IUS is hormonal, it is superior to the copper iodine. With the levonorgestrel IUS, there is a protection against iron deficiency anemia, treats heavy women blood loss. This is also used to treat painful monthly bleeding and provide progestin in the HRT. The cost of the levonorgestrel is expensive, while the copper iodine is readily available and free in all government hospitals. For the effectiveness, both levonorgestrel iodine and copper iodine produces less than 1 pregnancy per 100 women in the first year of use. The return of fertility of both methods are immediate. For the levonorgestrel, we can insert it in the first 7 days of menstrual cycle, while on the copper iodine, we could insert it for the first 12 days of menses. In cases of postpartum women who is breastfeeding or not, both of the levonorgestrel and copper iodine can be inserted within 48 hours after delivery, or if after 48 hours, we delay the insertion until at least 4 weeks. In cases of post-abortal, we could insert the levonorgestrel and copper iodine within the first 12 days after the miscarriage. In cases that the client is switching from another method, we can provide both LNG-IUS and copper iodine immediately. No need to wait the menses to occur and no need for backup methods. We can provide the LNG-IUS or copper iodine when the next injection is due. We also have to know the contraindication of insertion during the postpartum period. It is category 4 or we do not provide the method if the client experiences a chorioamnionitis, puerperal sepsis, postpartum endometritis or metritis, and if a client have unresolved postpartum hemorrhage. We also do not provide the method for clients between 48 hours and 4 weeks postpartum, and for cases of prolonged rupture of membrane more than 18 hours. Before we insert any IUD or IUS method, we should assess if there is an STI or sexually transmitted infection risk. We also do not provide a method in clients who are at risk of sexually transmitted infection. So we have to evaluate if a client has more than one sexual partner, if she has sexual partner who has had other partners recently, or when a client have a sexual partner who experiences STI symptoms such as pus coming from the penis, experiences pain or burning sensation during urination, or an open sore in the genital area. The permanent method for the female client is the bilateral tubalization. It is a mini laparotomy procedure wherein we tie and cut the fallopian tube. For the male clients, we are doing the non-septal vasectomy, wherein it is a minor surgery that the piece of the vas deferens pulled through the opening of the scrotal skin and being tied and cut. The vas deferens are the tube where the sperm passes through. We have considerations of family planning provisions in time of pandemic. So during pandemic, the family planning methods that can be provided immediately before they leave the facility or after giving birth are as follows. The lactation amenorrhea method, the condom, progestin-only pill, progestin subdermal implants, and the IUD. We have to consider that there is a limitation of movement of people during pandemic. Hence, we lessen the frequency of follow-up visits. We have to provide a 1-year supply of pills or condom for our clients, or provide a long-acting method such as the progestin-only injectable that is being administered every 3 months or every 2 months, or the progestin subdermal implant, which is effective for 3 years, or an IUD method, which is effective for 12 years. The teleconsult or telemedicine must be available in our setup. The key messages for today's lecture is that family planning methods are very safe and effective in population reduction, maternal child mortality, and morbidity reduction as well. There are different kinds of modern family planning methods that are available in our country. My references for the lecture today are the following: a global handbook for providers of the family planning 2018 edition, the clinical practice guideline on family planning, and the medical eligibility criteria for contraceptive methods. And with that, thank you for your kind attention. Have a great day.